Hi everyone. In this video, we are going to discuss about the two important topics, that is envenomation and also drowning in the case of the children. So first we begin with the envenomation. It is usually asked as a short note on the envenomation, that is regarding the snake bite and management. So we have to discuss in detail. So uh, there will be the types of snakes can be classified as venomous snakes and non-venomous snakes. The venomous snakes, which can be again classified as neurotonic, hematonic, mixed, and myotonic. And the neurotoxic are the cobra and crate are the neurotoxics. The cobra and crate snakes are the neurotoxic snakes. Then we have the hematotoxics are the viper, that is the saw-scaled viper and the hump-nosed viper, which are the hematotoxic, and the mixed that is neurotoxin, hematotoxic are the Russell viper, and the myotoxic are the all sea snakes are the myotoxic venomous snake. So neurotoxic are the cobra and the crate, and hematotoxic are the viper, and mixed is the Russell viper, and the myotoxics are the all sea snakes. So these are the classification of snakes. Usually, if the child is in the rural or the outdoor and agricultural areas, he should be caught with the snake bite. So we have to consider in that in our mind. Then about the pathogenesis, the neurotoxic venomous snakes will cause produce the toxin which intervenes with the acetylcholine activity at the synapse. And the cobra, which have the alpha bungarotoxin, and crate we have the beta bungarotoxin. The hematotoxic venomous snakes which have releases toxin which neutralizes the clotting factors, and that will impair the function of clotting factors, and that will causes the bleeding. That is the action of the hematotoxic venomous snakes. So then coming to the signs and symptoms of the snake bite, that is there will be psychosocial because of this neuropsychiatric, that is because of neurotoxic venoms, there will be psychosocial symptoms like a fright, that is fear of death and anxiety. The local symptoms are there, that is pain, tenderness, swelling, and bleeding, and necrosis will be there at the site of bite of the snake. Then we have the systemic signs, like in the case of the neurotoxic venomous snakes bite, there will be the descending, that is neurotoxic, that is it affects the neurons, that is there will be descending paralysis, that therefore there will be ptosis and diplopia will be there. Then we have the tongue and jaw paralysis. So there will be aspiration of the secretions that will cause the aspiration pneumonia and all the, and also there will be numbness and respiratory failure due to the diaphragm paralysis, and also in the serious there will be tachycardia and hypotension. So these are the effect of the neurotoxic venoms on the systems on the body, that is descending paralysis which results in the ptosis and diplopia. Then tongue and jaw paralysis results in the aspiration of the secretion, then numbness, respiratory failure due to the diaphragm paralysis, and the serious there will be tachycardia and hypotension. But in the case of the hemotoxic snake bite, that is hemotoxic venomous snake bite, there will be more signs are because of the bleeding. That is bleeding first at the gums, that is followed by the injection site. That is there will be first the bleeding happens at the gum, then that is followed by the injection site. Then epistaxis, hematuria, hematemesis will be there, and purpura and petechia and intracranial hemorrhage will be there, and acute rheumatic fever and shock will be there. So these are the clinical manifestation of the snake bite. Therefore, that is first we have psychosocial factors like anxiety and fright, and local symptoms, pain, tenderness, swelling, and bleeding and necrosis, and the systemic signs because of neurotoxic and as well as the hematotoxic. Hematotoxic most due to bleeding, and the neurotoxic is due to most commonly the paralysis, that is descending paralysis, tongue and jaw paralysis, like that. Then what are the investigation we have to done in the case of snake bite? That is, we have to do a routine complete blood count, RFT, and prothrombin time and liver function test, and 20 minutes whole blood clotting time should be assessed. That if blood does not clot, it suggests viper poisoning. That is, usually the viper poisoning is hematotoxic, that will intervene with the clotting factors. Therefore, there will be a deficiency in the clotting factors and the blood does not clot. Then about the management, what are the do's and don'ts we done in the case of snake bite management? The do's are the we have to reassure the patient and bystanders and immobilize the patient's bitten parts, and they try to keep the patient in the left lateral position, and urgent shift to the hospital is required. So these are the do's we should done in the case of the snake bite management. And what are the don'ts? That is, we don't do these things, that is manipulate bitten area, local ligature, cut or the incise wound, and need to identify the snake. These are the don'ts which are usually we do not have to do in the case of snake bite management. The right approach is the rest, immobilization, getting into hospital and telling the doctor about the signs and symptoms. Then we have to provide the supportive care, that is airway, breathing, circulation, that is ABC. That is, we have to give IV fluids, oxygen support, and respiratory support by the ventilatory support, which may be needed if the patient is unable to perform a neck lift. Then we have to done a local wound management, that is clean thoroughly and keep open. It is no need to dress the wound. Then wound debridement is needed on third or fourth day. Hourly progression of edema is reviewed. Then about the specific, these are the supportive care and the local wound management. Then about the specific treatment of the snake bite management, will be we have to administer anti-snake venom. That is, anti-snake venom is a polyvalent which is available in India. Dose is 10 vials of, that is, the we have to supply the 10 vials of the anti-snake venom dried powder, that is irrespective of the weight, diluted in the 100 ml of normal saline given 1/1 hour. That is, 10 vials of anti-snake venom dried powder should be diluted in the 100 ml of normal saline, that is given over the 1 hour, and repeated after 1 hour in neurotoxin, that is maximum 20 vials, and 6 hours in the hematotoxin, that is maximum 30 vials. That is, after 1 hour in the neurotoxin, we have to repeat the dose, and after the 6 hours in hematotoxic venomous snake bite, we have to repeat the dose. That is, maximum 30 vials are required in the case of the hematotoxic, and maximum 20 vials which are used for the neurotoxins. And the side effects of the anti-snake venoms are the anaphylaxis and serum sickness. And it is the anti-snake venom is indicated if there is any when the signs of local or the systemic envenomation is present. That is, if there is any local envenomation, the features are greater than one half of the limb edema will be there, the swelling on digits after bite, and very rapid expansion of swelling. These are the local envenomation signs which are the indication for the anti-snake venom administration. The systemic envenomation signs are the hemostatic abnormalities like bleeding, neurotoxic abnormalities like any paralysis, and shock and acute kidney injury. These are the systemic envenomation indication for the anti-snake venom administration. Then we have to give neostigmine and atropine. That is, neostigmine and atropine 0.04 milligram per kilogram plus 0.005 milligram per kilogram atropine respectively. Then mechanism of action is that it prolongs the, that is, most of the neurotoxic effect is due to the prolonged action of the acetylcholines. So, in the mechanism of action, neostigmine and atropine are they prolong the acetylcholine esterase action by the inhibiting ACH esterase. That is usually the toxins, that is neurotoxins, which interface with the acetylcholine action. So, the neostigmine and atropine mechanism of action are it prolongs the ACH action by the inhibiting ACH esterase. And also, if there is any need for the antibiotics, we have to supplement the antibiotics. Then also, we have to administer the TT prophylaxis to this patient. And no role of heparin or the botrope is in hematotoxic envenomation. It is usually harmful. So these are the these are all about the envenomation, that is pathogenesis, that is both neurotoxic and hematotoxic. Neurotoxic, that goes interface with the acetylcholine at the synapse action. Then hematotoxic, that which neutralizes clotting factors which cause bleeding. Then signs and symptoms, psychosocial, local symptoms, systemic symptoms, that is either neurotoxic and hematotoxic. Then about the investigation, and then about the management, that is do's and don'ts. Then the supportive management, local wound management, specific treatment with anti-snake venom and neostigmine and atropine. And when we need it, that will be we have to provide the antibiotics, and TT prophylaxis should be done. So that is all about the envenomation. Then a short answer is or short note is asked regarding the drowning. That is, drowning, it is a leading cause of accidental deaths in the children and is largely preventable. So definition of WHO definition for the drowning is that it is defined as a process resulting in the primary respiratory impairment from the submersion or immersion in a liquid medium. That is because of the submersion or the immersion in a liquid medium, that will be resulting in the primary respiratory impairment. That is known as the drowning. Then about the some certain data about the epidemiology and causes. Leading cause of death in 5 to 40 years of age is drowning and is more common in the males. And the peak age is at 0 to 4 years of age, and again in the adolescents at 60 to 80 years of age. And the common sites of drowning are the swimming pools, bathtubs, commode, and washing machine in the urban areas, wells, ponds, and large buckets in the rural areas. Alcoholism and drugs play a role in the adolescents and children with epilepsy and long QT syndrome, which are more susceptible for the drowning. Then about the pathophysiology of the drowning, that is the definition itself says that it is due to the submersion or the immersion in the water, and the submersion which causes the underwater breathing or aspiration of the fluid into the lungs, and that causes the altered surfactant synthesis, and which causes the ethylene gases or the collapse of the lung, and this causes the intrapulmonary shunting, systemic hypoxemia. That is because of the collapsing, there will be intrapulmonary shunting, systemic hypoxemia, and that causes the increased capillary permeability to the and that causes the because of the hypoxemia, there will be increased capillary permeability, and that will result in the pulmonary edema that will constitute all the signs and symptoms of the or the complications of the drowning. So that is all about the drowning. Then about the consequences of drowning, there will be because of the continuous submersion in the water, there will be hypothermia, regurgitation, and aspiration. There will be pulmonary edema because of this atelectasis and the capillary permeability alterations. Then pneumonia, hypoxic ischemic encephalopathy because of hypoxemia, electrolyte abnormalities, rhabdomyolysis, renal dysfunction, and arrhythmias and trauma. So these are the consequences of the drowning. Then about the clinical features. That is the clinical features which are predominantly related to respiratory as well as the nervous system. Respiratory because of the aspiration of the atelectasis and pulmonary edema, and the nervous system that is due to any hypoxemic effect. In the CNS, because of the hypoxemia, there will be altered sensorium, coma, convulsions, and even neurological deficit which may occur because of the defective oxygenation. Then we have the respiratory symptoms like respiratory distress, cyanosis, crepitations, and congestive heart failure. And the head and cervical spine injury should be ruled out in all the cases of the drowning. Then how will you investigate for the drowning cases? That is, we have to first take an X-ray chest. Patchy opacities due to the pneumonia, features of pulmonary edema will be there in the case of X-ray chest in the case of drowning. Then we have to look for biochemical changes like we have to look for the acid-base analysis, that is hypoxemia, hypercarbia, metabolic acidosis on the ABGA, along with electrolyte disturbances like hyponatremia, hypernatremia, and hyperkalemia. So we have to look for these electrolyte changes, that is biochemical changes. Then we have to evaluate for the hematology, that is hemo concentration, leukocytosis, and DIC if complicated. And we have to go for pulmonary function test, which may reveal the ventilation perfusion mismatch. Then we have to go for renal function test and liver function test, and also we have to do a ECG monitoring. So X-ray just biochemical changes assessment, then hematology, pulmonary function test, RFT and LFT, and ECG. Then about the treatment, we have to immediately resuscitate the patient when a patient is coming as drowning case. The immediate resuscitation to be initiated promptly. Some form of bystanders CPR better than none. During the CPR, adequate ventilation and chest compression ratio to be maintained without making much effort to clear the airway of aspirated water. Then this is the immediate resuscitation. Then about the treatment of complications, because of the complications like hypothermia, we have to provide the rewarming for the hypothermia, respiratory management with oxygen therapy and ventilator support as needed. Then acute respiratory distress syndrome, air leaks, pneumonia should be diagnosed and treated. No role of prophylactic corticosteroids. And we have to also we have to manage the neurologic symptoms, that is monitor with the Glasgow Coma Scale and raised ICP and seizures to be diagnosed and managed. Then we have to correct the acid-base and electrolyte disturbances. Then also cardiovascular management to facilitate the perfusion to vital organs. So These are regarding the treatment, that is immediate resuscitation, then the treatment of complication, then neurological management, cardiovascular management, correction of the acid-base balance, and electrolyte disturbance. So this is the algorithm for the drowning victim. That is, in the drowning victim, if the breathing is present, uh, we have to look for the pulmonary edema. And if the pulmonary edema is present, we have to look for the shock. If the shock is present, we have to provide the crystalloids or the colloids, vasopressors, and oxygen or ventilation. And if the shock is not present, we have to administer oxygen 50 liter per minute, ventilation, sedation, and normalizes the pH. And if there is any few crepitations are present, we have to give oxygen 5 liter per minute, admit for 6 to 8 hours, and chest X-ray and acid-base gas analysis should be done. And if there is any normal with the if the breathing is present, that it is normal with the cough, warm and calm, make the patient calm, warm and calm. Then about the that is, if the breathing is not present, we have to look for the carotid pulse, it is present or not. If the carotid pulse is present, we have to give the artificial ventilation. Oxygen should be administered 50 liter per minute. And if the carotid pulse is absent, uh, if submerged is greater than 1 hour, rigor mortis and putrefaction is present, dead not resuscitate. That is, this is the antemortem changes in the case, or the postmortem changes in the case of the drownings. So if the submerged is for more than 1 hour and rigor mortis and putrefaction is present, it is a confirmed case of death. That is, do not resuscitate the patient. But if the carotid pulse is absent and the time period is not more than 1 hour and the rigor mortis and putrefaction is not present, the CPR defibrillate should be given. IV epinephrine resuscitate until temperature is greater than 30 degrees Celsius. So that is all regarding the drowning in the case of the child. So that is all about this video. Thank you.